webinar, Depression Screening and SBIRT for Adolescents, some practical considerations for implementing the CCO incentive metrics. Just a couple of logistical things before I turn things over to our presenters. We definitely want to hear from you. We're assuming that the many people who have registered and will join the webinar today have questions. Because there are so many of you, everyone is and will remain on mute for the entire presentation. But that doesn't mean that we don't want those questions. So as they come up, no need to wait until Q&A starts. As they come up, go ahead and type them into the questions pane on the GoToWebinar control panel, and we'll be able to get to those right when Q&A begins. The one question that I know everyone has is, will the slides be available for this webinar? And they will, and a recording will be as well, and they'll be posted to the Institute website by the end of today, so you'll be able to access them and send them along to colleagues who maybe didn't have a chance to join us this morning. That brings me to my next point, which is this webinar is hosted through the Patient-Centered Primary Care Institute. We offer a lot of materials for folks working on the PC-PCH model of care, or medical home more broadly. It's a partnership with the Oregon Health Authority to get technical assistance out to folks. So we encourage you to visit and poke around the website if you haven't already, pcpci.org. You can access webinars, webinar recordings like this one, and a variety of other resources available to you. As I said, the Institute is a partnership with the Oregon Health Authority. The PC-PCH program is a model that defines medical homeness for practices in Oregon. There are a set of standards the practices attest to be recognized as a patient-centered primary care home. You can learn more about those standards in the PC-PCH program on their website, primarycarehome.oregon.gov. And I am pleased to introduce the presenters of our webinar today. We have Colleen Ruland, who's the director of the Oregon Pediatric Improvement Partnership. She has over 17 years of experience working with primary care practices and health systems to improve the quality of care provided to children and adolescents. She also has extensive experience with developing and implementing reliable and valid quality measures based on claims and electronic medical record data. A key component of her work has been focused on adolescent preventive services and implementation of Bright Futures recommendations. Over the last 3 years, the Oregon Pediatric Improvement Partnership has worked with numerous practices to implement depression and substance abuse screening and follow-up. Through this work, OPIP has identified a number of policy barriers and opportunities for improvement that we're going to hear about on the webinar this morning. Joining Colleen is Dr. RJ Gillespie, who has extensive experience in practice-based quality improvement, medical home implementation, and implementation of practice-based screening protocols in primary care. He's actively involved as a member and advisor to a number of local quality improvement initiatives and state policy committees, including the Patient-Centered Primary Care Home, or PC-PCH, Standards Advisory Committee, and the Oregon Health Authority's Metrics and Scoring Committee, which decides quality and incentive metrics for the Coordinated Care Organizations, or CCOs, in Oregon. And also Elizabeth Thorne is the Adolescent Health Policy and Assessment Specialist for the Oregon Public Health Division. She conducts statewide surveillance of a broad range of adolescent health issues and supports the development and evaluation of evidence-based policies, programs, and practices that support the healthy development of youth in Oregon. So we are clearly in good hands, and I will turn things over to our presenters to get started.
Thanks, Kate. I know that RJ, and Liz are really excited about this webinar because we've just experienced a lot of questions, and in working with practices, the complexity of kind of implementing the care processes that are aligned with the CCO incentive metrics is just something that we think practices need a lot of support on, and so that's our goal for this webinar. So in terms of our objectives, we wanted to start just really briefly with the rationale for why adolescents were included in the CCO incentive metrics, highlight where you can find the specific CCO guidance, but really spend most of our time talking about how do you actually implement the kinds of screens in practice settings that would be aligned with the metrics. And then most importantly, what are some of the really important issues to consider before using the billing codes or documentation in the EMR, specifically for adolescents. So what are ways that you need to implement processes related to privacy and confidentiality, depression screening and follow-up, and substance abuse screening and follow-up. I want to note that for this webinar, we chose to take a strategy of going for breadth. So we're not going to be able to go into depth on any of the individual topics. We could spend a whole hour, for example, just on privacy and confidentiality. So what our goal was to give you enough information on the call to make you aware of the issue, lead you to resources that could help you think through how to do that, and then give you our contact information so that when you're in the weeds and really thinking through the devil of the detail, we'd be happy to follow up. We also chose to have a lot of slides so that we could be able to give you places to go. So we're saving time for questions at the end, but also have agreed to stay on a little past 9 so that we can answer questions. And then Q Corp also documents all the questions, and so if we don't get to your question, they'll send them to us, and then we can make sure that we address them individually in an email for you. Okay, so I'm going to pass to RJ to give us a little bit of context about the rationale for including adolescents in the metrics.
Good morning, and thank you for joining us. As you may or may not know, initially when the metrics around SBIRT and screening for depression were introduced into metrics and scoring, the first metrics were actually intended for adults aged 18 and over. And as a pediatrician, obviously I thought that we needed to include adolescents, and there are a number of reasons for that. If you go back to the American Academy of Pediatrics Mental Health Task Force, we've been advised as primary care physicians that we enhance our skills in mental health competencies, specifically around 4 conditions: depression, substance abuse, anxiety, and ADHD. And the reason for this is that all of us as primary care providers have been experiencing some degree of difficulty getting kids into mental health services, and so it doesn't really work as a primary care provider to just refer all mental health conditions out. I think there's been a little bit of a misperception that access to child and adolescent mental health is a specifically rural issue. All of us in urban settings are having similar problems. And what that means from a practical perspective is that primary care providers really have to be prepared to not only identify these conditions, but to do at least some first-line management. And so from my perspective, including adolescents in these measures reflects what we should be doing clinically. And so that's the primary reason. I think that we know that depression affects large numbers of adolescents. We know that suicide is a leading preventable cause of death in teenagers, and that up to 40% of chronically mentally ill adults actually had symptoms that presented in the teen years, and they often went unrecognized. And so in terms of, I guess, narrowing the pipeline of mentally ill adults, it's important for pediatricians and for family medicine providers who are caring for teenagers to think about how you can identify and start treating those patients early. We know that there are significant correlations with adolescent depression and substance abuse as well, and so these conditions often cross over between each other. And we know that early initiation of substance abuse is correlated with lifelong use and abuse, and so early detection and primary care management and hopefully prevention is going to be an important component of pediatric and adolescent care. There are multiple guidelines that have recommended annual screening in adolescents that have come from many different societies. So the Bright Futures recommendations, which is a joint project of the American Academy of Pediatrics and the Maternal Child Health Bureau, have both recommended that we do annual assessment for both depression and for substance abuse. Society for Adolescent Medicine also agrees with this, and then the Substance Abuse and Mental Health Services Administration, or SAMHSA, has also come out with recommendations that support these particular populations being screened and managed within primary care. The U.S. Preventive Service Task Force has assigned a B recommendation for the SBIRT process, recognizing that there is adequate evidence that numerous screening instruments can detect alcohol misuse with acceptable sensitivity and specificity, and furthermore, that early identification does make a difference. They've also recommended screening of adolescents from 12 to 18 years for major depressive disorder, with the caveat that systems need to be in place to ensure that accurate diagnosis and psychotherapy is available. So that is, screening is recommended when you can do adequate follow-up and treatment for those patients. In terms of the CCO incentive metrics and the details of the measures and how they're measured, we actually want to refer you to the guidance documents, and so the web link is written there on the slide so that you can see the details. But in terms of broad strokes, the substance abuse screening and brief intervention, or SBIRT measure, is a claims-based measure, and so there are a number of codes that we're going to be talking about that feed into that measure. Depression screening and follow-up to depression screening is, however, not a claims measure. It's based on meaningful use, and so it's data that's meant to be extracted from an electronic health record and submitted to each individual CCO or to OHA. The overall measure for SBIRT, though, is the numerator-denominator we've listed out here. The numerator, unique counts of members aged 12 years or older who completed a full standardized screening tool for alcohol and substance abuse, or who received screening and a brief intervention. The denominator is unique counts of members aged 12 or older having received an outpatient service. And I think that's an important distinction to notice, is that while most general pediatricians and family medicine providers who are doing screening do the screening in the context of a well visit, the measure is technically anybody who's received any outpatient service. There are no exclusion criteria or continuous enrollment criteria for this particular measure, and the technical specifications for the measure in terms of which claims codes are used are written in the guidance documents that I have referred to here. For depression screening and follow-up, it's important to recognize that this is a measure that is not just screening, but it also includes a follow-up plan for patients who are who screen positive for depression. And so the numerator is patient screened for depression on the date of the encounter using an age-appropriate standardized tool, and if positive, a follow-up plan is documented on the date of the positive screen. This is why this can't really be a claims-only measure, because it does require that there is documentation of a follow-up plan, which you can obviously get from claims. The denominator is all patients aged 12 years and older before the beginning of the measurement period with at least one eligible encounter during the measurement period. We recommend that you do check the specifications for specific exclusions and exceptions to the denominator, because on this measure there are a few exclusions and exceptions. For example, if you have an active diagnosis of depression or bipolar disorder, that is one of the exclusions. There are some exception rules for if patients refuse to participate, or if they're in an urgent or emergent situation where screening would not be appropriate based on triaging the needs of the patient. And the measurement period is over the previous 12 months or the last quarter of the measurement year, depending on your CCO. So again, technical specifications are going to be listed on the guidance documents, which we have referenced here.
So one of the reasons that we wanted to do this webinar is, in working with practices on implementation, we found that there was this kind of knee-jerk to just jump to doing the specific screen, so substance abuse screening or depression screening, and a knee-jerk reaction to just start billing. And what we think is really important, particularly for this population of adolescents, where you're trying to build them as a healthcare consumer, a responsible healthcare consumer, and you're trying to make sure that they actually come back, is to really think about the context in which that screening is being done. And particularly for adolescents, where there is this factor of the adolescent is often coming with their parent, it's really important before you start asking about things like substance abuse or depression to first make sure that the context has been set in terms of how you're going to use that information and how that information is confidential. And then in thinking of workflow around implementation of screening tools and workflow around using specific billing codes, have you kind of considered the really unique factors that play in terms of adolescence and what is shared with parents and what's not shared with parents? So what we wanted to focus the majority of this webinar on is really around that implementation. How would you do this well in the context of a Bright Futures recommended visit? And how would you address that confidentiality, privacy? And how would you implement the screening tool in a way that really fits with the model that's recommended for adolescents overall? So the way we've broken out the implementation and sharing with you some tips and strategies practices have used is to break it out into 3 parts. So the first thing that we're going to go through is confidential care. What are the laws? So Liz is going to do a great primer of what the laws are around confidentiality for adolescents, and then share with you some strategies practices have used to implement processes that are aligned with those laws. The second thing we're going to do is go through how have practices actually implemented screening tools for adolescents in practice that include both depression and substance abuse screening? And then the third thing we're going to go through, and I know we have a lot of office managers on the call, is really around for adolescents, what billing codes, there's a number of billing codes that you can consider for the SBIRT measure, for example. What billing codes might you consider for adolescents that take into account these issues around confidentiality? And then for the depression measure, which is not a claims-based measure, what are some strategies and ways practices have documented in a way that's aligned with the CCO incentive metric? So we're going to go through those three categories of implementation: confidentiality, implementation of broad screening tools that include both that depression and substance abuse screening, and then hone in on the specific billing codes and documentation requirements. So let's start first with a primer on what are the laws around confidentiality. Liz?
Thanks, Colleen. Hi, everybody. So I'm really happy to be here this morning, and as Colleen mentioned, we could spend many, many hours talking about all of the nuances and interpretations of adolescent consent and confidentiality issues, but I'm going to spend about 5 minutes giving you a high-level overview of the policy landscape related to consent and confidentiality, with a huge caveat that this is totally complex and nuanced, but it's a hugely important piece that's foundational to providing care for this population and has a lot of implications for doing SBIRT and depression screening, as both RJ and Colleen mentioned. So I'll start with providing just an overview of Oregon's minor consent laws. And so just so we have a shared understanding, consent is the ability to present for health care on your own without parental permission or consent. And our minor consent laws in Oregon are age-based. So for medical services and dental services that include a well visit, a sick care visit, or a sports physical, or for dental visits, a checkup, cleanings, or x-rays, an ER visit, vision care, and immunizations, anyone 15 and over can consent to that type of care all on their own. Youth 14 and over can consent to outpatient mental health, drug, or alcohol treatment, excluding methadone. But however, in this area, providers are expected to involve parents by the end of treatment unless it is clinically not indicated. So that's our one state minor consent law where the issue of family involvement is explicitly called out. But I think it goes without saying that most providers would agree that in most cases, having the family involved will lead to better outcomes for a youth unless that's not clinically indicated. And then youth of any age are able to self-consent to any family planning, sexual and reproductive health care services that includes testing and treatment for STIs, including HIV. And the Oregon Health Authority, our office, has produced a resource with the link here that provides some more detailed information about all of the different minor consent laws and how that impacts you as a provider. And also you can request copies of this booklet if you're interested in having them in your office. You can feel free to outreach to me and I'd be happy to get copies out to you. Now, confidentiality. Confidentiality differs from consent in that confidentiality is the ability for somebody's protected health information to not be disclosed to somebody else without their consent or authorization. And this is where things get a little bit tricky. The first piece is that confidentiality is really a tangled web of numerous federal laws, such as HIPAA, which essentially provides the federal floor for what can be done, what can be disclosed with protected health information. ERISA, which is the requirement for employee benefit plans, and rules over disclosures that mostly commercial employee-based benefit plans need to report to, what kind of disclosures they need to make to policyholders, and Title X, which is the federal family planning program. And then there's also an interaction with our state minor consent laws and regulations, as well as corporate policy if you're within a large health system, as well as professional ethical obligations. As RJ mentioned, there are a number of medical agencies and associations that have some standards when it comes to providing confidential care, particularly to adolescents, and then also best practice recommendations. So we'll talk a little bit about how the confluence of federal laws and regulations and state laws can create sort of an uncertainty for providers. So why is confidentiality important? As Colleen alluded to, it's particularly important for young people for a couple of reasons. First of all, I think anybody who is seeking services in a healthcare setting expects some type of confidentiality when they're in a one-on-one discussion with their provider. It's really an underlying foundation of healthcare. And we also know that young people are more likely to disclose sensitive information if they know it will be kept confidential. This is especially important for issues like mental health and substance use. And we also know that young people will delay seeking care if they don't think that their information will be kept private, or they could face real emotional or physical repercussions if an adult in their life, like a parent or a guardian, were to find out that information. And it's a challenge for the reasons that I've already alluded to. There are a lot of federal and state and agency policies that are at work here. And it's not just when there's a parent coming and asking for youth information. There are challenges or sort of breaks in the chain where confidential information can be inadvertently disclosed throughout the patient experience of care. So when you're setting up a clinic workflow, like appointment setting, and any type of client communication, whether that's through an after-visit summary, appointment reminders, or via a patient portal, and within electronic health records and health information exchange, and then insurance billing and communication is a huge one. So the big take-home that I would like folks to get from this piece of my discussion is that there is really no legal right, quote unquote, for a young person to have confidentiality, nor is there a right for parents to have information disclosed to them. So HIPAA, as I mentioned, sets the federal floor for when protected health information must be disclosed. And they essentially, on this issue, defer to any state rule or state laws. And Oregon law neither prohibits nor requires disclosure of information from a minor to their parents. Instead, it defers to providers' best judgment. So essentially, the provider, for better or for worse, is left with all of the decision-making authority as to whether they think that information should be disclosed to a parent or a guardian. There are a few exceptions. If a minor is able to self-consent for drug or alcohol treatment, and again in Oregon that's at 14 years or older, treatment records, and that's a very specific type of information, cannot be released without the minor's written consent, and that's a federal regulation. In another instance, if a young person sought services, reproductive health services, in a Title X family planning clinic, that information cannot be released without their consent. Title X has some of the strongest confidentiality protection protocols in the nation. And there are some limits to consent and confidentiality that all young people should be made aware of within the context of this type of a visit. And as medical providers, you are mandatory reporters, so there are limits to confidentiality, and information must be released if the young person is at risk of harming themselves or others, or if there's an instance of abuse. And so it's really important within the context of your workflow that you build in a discussion of when confidentiality cannot be kept, either within the instance of a mandatory reporting case. And it's also really important to know your workflow, know the gaps in your own workflow where confidential information may inadvertently be disclosed. I'm going to turn it back over to Colleen, and again, I'm available for questions and more information because I know that was a super high-level overview.
Okay, so how do practices actually address what Liz just talked about? And in working with practices, there's kind of three main categories of work that practices have done to address this issue around confidentiality. The one is they've created explicit processes that actually transition that adolescent, rather than the family that's with the adolescent, to being the primary patient, which involves intentional, repeated, starting at 12 kind of conversations with, we're going to be transitioning to the adolescent being the patient, we're going to have the adolescent on their own during part of the visit, and creating really explicit policies within the practice around that transition. The second way practices are addressing this is in giving really explicit information, both verbally and written, about this issue of what is private and what is confidential. And then the third is giving written information about what to expect in a well visit. So this context of the kinds of questions that are going to be asked and how that information is going to be used is shared with both the adolescent and with the parent. So some resources for you, because again, we could spend a whole hour just on this. This is an example of an adolescent transition policy that's from RJ's clinic, actually, the children's clinic. And one of the great resources that's at the bottom of the slide is a website called gottransition.org. And they have extremely helpful tools for practices. So they have tools specific to family medicine practices that are transitioning that adolescent to being the primary patient, and specific tools for pediatric practices. The second thing that practices have done is really having kind of clear written information. So what you'll see on all of these slides is we have a link to the specific tool that I'm highlighting. So some practices have kind of created a cheat sheet of what are their rights for teens that outlines what Liz just shared. Other practices have had cheat sheets that explain not only what is going to happen during the visit, so what's going to happen during the context of the well visit, but also how that information is going to be shared. And they've created cheat sheets for teens and created cheat sheets for parents. And again, the link has some examples of tools. And then this is an example of a tool used by the Multnomah County Health Department that really kind of goes through the same thing. What do the laws allow, and how are things going to be used? So as Liz mentioned, one of the really important things that when we're working with practices, we have them kind of map out from a workflow point of view, are all the places where potential breaches of confidentiality can occur. So think through, how are you sending visit reminders? Do those visit reminders go to the parent? Is that visit for a visit that the teen may be scheduled on their own? The after-visit summaries, one of the things that's been noted by a lot of practices who are trying to go for meaningful use is the requirement around printing medications. Well, what if that teen's on birth control? Does that violate some of the agreements that the provider had with the adolescent around what would be shared? And then obviously, particularly relevant to some of the discussions we're going to have later around documenting in the EMR in a way that's aligned with the incentive metrics is, what is documented is what can be read. And so if a parent has access to that medical record, then the parent has access to that information. And then lastly, the explanation of benefits. So depending upon what you code and bill, so again, we're going to go through this in detail, then that is going to be shared with the parent. So if you code specifically for substance abuse and intervention, then that will be shared with the parent. So it's really just important to think through a workflow of what are you doing, and then how are you going to make sure you communicate that with the adolescent, and how do you communicate that with the parent? Okay, so moving on to the next part. So again, the incentive metrics are specific to two types of screening, substance abuse screening and depression screening. But when you kind of look at the literature around adolescents, one of the things that's really important is thinking about the context of when to do an adolescent screening and the value of risk and strength-based screening. So we wanted to share, again, just a highlight of some tools that practices have used to really implement those screening tools, but in the context of broader recommendations for adolescents. So again, we could spend a whole hour just on this topic, and so I'm just going to highlight specific strategies, but guide you to places where there's a lot more information. So we did a webinar on just this topic of using broad risk and strength-based screening tools that's found here. Additionally, the Oregon Pediatric Society START program has funding from the Oregon Health Authority from Adolescent Health and Addictions and Mental Health. And they've created a couple of great training modules that have really great training specific to depression screening and specific to substance abuse screening. And then they're creating these wonderful videos that kind of walk through how would you actually implement brief intervention. So there's some good resources if you want to spend a lot more time on this topic area. But let me share just a couple of quick highlights from practices that have implemented and what they learned. So again, although the eligibility criteria is all encounters, for a lot of practices, that we worked with, actually all of them, they first built it into their well visits because there's a lot of issues with doing opportunistic screening, particularly related to this issue of how are you going to get that adolescent alone, one-on-one. If they had a concussion, is that really the best time to screen them? So most of our practices from a workflow point of view started first with implementing in the context of a well visit. And again, because it was part of a well visit and because there's many things that are recommended in a well visit, they chose to use a more broad tool that addressed all of the recommendations for bright futures in terms of screening and strength identification. Again, we're going from a world that's really changing in terms of what adolescents experience in their well visits. And one of the kind of unanimous things that practices have found is that you don't just want to talk about sex, drugs, and rock and roll. You actually want to talk about what they like and what they want to do and what their strengths are. One, because that's just going to be a more adolescent-centered visit. But two, that's also going to give you really important information that you're going to need in order to address any risks that are identified. Particularly with an adolescent where you're trying to help them kind of weigh pros and cons, it's going to be helpful to know, well, what are their goals in life? What are some of their strengths? What you'll see later on is that for some of the practices we've worked with, they've also had a parent complete a tool. So you have the adolescent complete a tool that has those screening tools, but you also have a parent complete a tool. And that's been valuable in terms of distracting the parent while the adolescent is completing theirs, but also the parent giving you really valid information from the parent's point of view. And then also gives you information that you can talk about with the parent when the adolescent's in the room. And then the last one is just really critical, is that when a practice is designing strategies for implementing screening tools, one of the really important factors they have to take into account is when are they going to review those results alone with the provider. So somewhere in that well visit context there needs to be one-on-one time. So examples of these kind of broad strength and risk-based screening tools are in the website attached, and again, I don't have time to go through them, but I think that they will be very helpful. So just specific to the substance abuse, the CCO incentive metric, and for adolescents, the screen that's generally recommended for adolescents is the CRAFT, and the CCO guidance document counts the CRAFT as a full screener if a discussion is had with the adolescent about the results. And again, some of the really important things for adolescents is that you're not just screening for the risk, but you're also, for those adolescents that don't have any risk, taking it as an opportunity to talk about anticipatory guidance and reinforcing the good choices and behaviors and low risk that the adolescents have done, and then obviously addressing those high-risk adolescents. So in terms of depression, while there are a number of tools recommended for adults, the ones that are most commonly used for adolescents are the PHQ-2 or the PHQ-9 modified for teens. One thing that's really important to know about the CCO incentive metric is that practices that are doing the PHQ-2 and then based on the results of the PHQ-2 who then use the PHQ-9, the PHQ-9 can be considered a follow-up step. So again, the measure is those identified at risk who received follow-up. The PHQ-9 can be considered a follow-up step for the PHQ-2. And again, the link here has an example of that PHQ-9 that's specific for adolescents. So again, for those family medicine practices that are doing this for adults, it's really important to make sure you're using the tool that is specific for adolescents that has some of the follow-up questions. Okay, so in terms of workflow, I'm just going to share briefly a couple of strategies that, that we have. First, we have some practices that, again, are giving the parent a screening tool and the adolescent are getting a screening tool, and they're doing that in the waiting room. And then the provider is taking the adolescent back alone first and reviewing the results of the adolescent, and then bringing the parent back in the room. Another strategy practices are using is having, again, the adolescent fill out the screening tool in the waiting room, bringing the parent and the adolescent into the exam room, having a discussion, then asking the parent to leave for part of the visit, having that alone time with the adolescent, and then ending the visit with the parent coming back in and having a discussion about what the provider and the adolescent agreed would be shared with the parent. Oh, it froze on me. And then the last strategy that some practices are using is they first bring the parent and the adolescent into the exam room. They talk about things, then they have the parent leave, and after the parent leaves, they have the adolescent fill out the screening tool. The provider reviews the screening tool with the adolescent, and then they have the parent come back in. Again, it depends on your workflow, it depends on the number of rooms you have, it depends on your process, it depends on how long the tool is that you guys are using. Okay, so let's end the webinar in terms of going through implementation around how do you actually do the billing and documentation that is aligned with the CCO incentive metric.
All right, so the first thing to say about the billing and the documentation is that there have been some gray areas, and we've seen a lot of variations between different CCOs in different regions of the state. So it's always important when you're thinking about the billing to check this with your local CCO and see how your particular billing is going to fly. It's also important to remember that there may be some differences between your publicly insured patients and your privately insured patients in terms of what codes are covered. However, billing needs to be done universally, and you can't do things just for publicly insured. That is considered fraud. So you will need to, again, take into consideration that some privately insured patients may have differences in their billing and reimbursement. So you have to take that into account. My office spent a lot of time talking about what we're going to do with rejected claims from our privately insured and what we write off and so forth. So that's just something to keep in mind. Furthermore, some plans may charge some of the screening tools to a procedural deductible, and so sometimes there are charges that end up going to the family if they have that type of plan. Most of us have found that using some of the modifiers, like the 2.5 modifier and the 3.3 modifier, will reduce the likelihood of it being applied to a procedural deductible. So again, just keep that in consideration. But again, when in doubt, check first, see what your plans are going to be covering. So we're going to talk just briefly about the billing and documentation for adolescents, given the factors that we've just discussed about confidentiality. And for family medicine providers, these may not be as important or as applicable for adult patients, so just keep that in mind as well. We have put an email in here for people who have specific questions about how to interpret the specifics within your CCO and the technical specifications. So the email is there if you do have any further questions after we've talked through this. All right, so just to remind you, the SBIRT, what the numerator denominator is. So again, unique count of members age 12 or older who completed a full standardized screening tool for alcohol and substance abuse or who received screening and a brief intervention. The denominator is unique counts of all members age 12 and older who had an outpatient service. So again, this does count for any outpatient service technically, although most of us, as we've described, have been anchoring this specifically to well child visits. So for the SBIRT, there are kind of two pieces to this. There's the screening piece, and then there's the brief intervention. And so there's some billing codes that are aligned for each part. When we're talking about the screening, there are diagnosis codes that are attached to these specific screenings. There are two. There's the V79.1 and the V82.9, and these are attached to the CPT code 99420. The 99420 is screening for general conditions, so that is a non-specific code for screening tools. The V79.1 in the explanation of benefits will read as a screening for alcohol use and abuse. And for the CCO incentive metric, this can be used as a standalone code, so it doesn't have to be attached to any other specific kind of visit. So keep in mind, though, that on explanation of benefits, it will say screening for alcohol use and abuse. So remember the confidentiality implications of this. The V82.9 is screening for a general condition. Since this is in the explanation of benefits more of a blank, generic screening tool, most of us are using this tool when we screen in the context of a well visit. Now, it's important to remember that for the CCO incentive metric, you cannot use this as a standalone code, so it does have to be in the context of a well visit if you use the V82.9. But many of us feel that this does protect confidentiality a little bit better because it doesn't create the same flag if you say screening for general condition. So if you use the specific code, you may have to have a plan for how to explain to parents that may get an explanation of benefits what that screening tool actually was. And obviously what many parents are going to want to know are what was the result of that screening tool if you screen for alcohol use and substance abuse. And so that's where the confidentiality piece really comes into play. We do recommend using a 2.5 modifier to indicate that the 99420 was part of a well child visit. You can use a modifier 3.3, which is a code that says that it is a Bright Futures recommendation, which for some health plans help to speed that through. If it's a Bright Futures recommended service, then that is covered under ACA guidelines, so just something to keep in mind. There are no specific time limitations that are stuck on the screening code as there are for the brief intervention code, so we're going to talk about that in a second. But keep in mind for adolescents that the craft will count as a full screen if you've had a discussion about the results with the patient. So it's not good enough to just use the craft and then not talk about the results. So again, you would be reinforcing good choices of low-risk adolescents and then hopefully trying to get to some behavior change with patients who screen higher on the craft. As far as the brief intervention piece, there are 2 additional codes that can be used if you've gone into a longer brief intervention with a patient who had a positive screen. These are time-based codes, so the 99408 is used for patients who had a screening and had a brief intervention that lasted between 15 and 30 minutes. The 99409 is used for longer interventions, so those would be for patients who screened positive and had a brief intervention that lasted longer than 30 minutes. In the guidance documents, there are some Medicare G codes that have been included as well. So it's generally not applicable to pediatrics, although we've had one practice that had an internal agreement with their local CCO where they were using the G codes primarily for tracking. So that practice didn't get reimbursed for it, but they used the G codes to help the CCO track. So just keep in mind that within your region, check with your CCO and see if that's what they prefer. But there's more information about those specific G codes in the guidance documents. So in terms of what you have to document for an SBIRT, and this again comes from the CCO guidance documents, the first piece, the total face-to-face time with the patient, and that is because the SBIRT codes are time-based. So if you're billing for a 99408 or 409, you have to document how much time you spent with that patient in counseling. It's recommended that you write down, and this to me is a little bit backwards, so we'll start at the bottom. For each patient encounter, you would document the reason for the encounter, the relevant history, the date and identity of the provider, obviously, any physical exam findings and prior diagnostic test results, the assessment, clinical impression and diagnosis, and then the plan of care. In that, you're going to include some information about the patient's progress, any response to changes in treatment and revisions of diagnosis, and then rationale for ordering any diagnostic or ancillary services, or ensure that it can be easily inferred from what you've documented. What goes into the plan of care? And I think this really comes back to motivational interviewing and to strength-based approaches to care. So in terms of motivational interviewing, it's really about kind of figuring out what are the patient's goals, how prepared are they to make a change, and then what sort of steps will they need to take to make that change, and what things might get in the way of them making those changes. And I always think it's important to remember that in terms of motivational interviewing and in terms of change, cutting back can be as important as quitting. So, you know, if you have a patient who's smoking 2 packs a day, God forbid, if they were to cut back a half pack a day, that's progress, right? So I think as pediatricians anyway, we try to have this all or nothing approach, you know, that you want to try to get them down to 0, and ultimately that may be our goal. But make sure that you're celebrating small changes with your patients. So cutting back can be just as important as a full quit. So again, we try to document goals, their readiness for change, any barriers to change. So what are the patient's triggers? What sort of things get in the way of them having better coping skills? And then also any referrals that were done and any follow-up that you plan to do. For the depression screening and follow-up, again, just to super emphasize that the CCO incentive metric is not claim-based, and it is not for screening alone. So it's an electronic health record-based metric that is really based on the outcome of the screening. So not only did you screen, but did you get a follow-up plan done? So here's some options for considering billing for screening, which some practices do and some don't. And many practices find that using some of these CPT codes help with tracking internally which patients have been screened so that you can identify who you need to pull out follow-up plans in terms of your documentation for. So again, in general, the 2-5 modifier is helpful when you use that in the context of a well visit. And some practices have also found success with using that Bright Futures 3-3 modifier as well. And again, remember that the confidentiality issues are going to come into play because this is technically a mental health service. So one option, and this is a relatively new CPT code, it's 96127, and this is a CPT code that is for screening for emotional and behavioral screening tools. So in theory, it can be used for either a PHQ-2 or a PHQ-9, and again, use that 2-5 modifier. The second option would be to go back to that 99420, which is a non-specific screening tool. So a couple of caveats to that. First of all, some payers may not reimburse for 2 99420s within the same visit. So you just need to check that with your contracts and health plans. The second is that if you're doing internal tracking, you're going to want to be able to distinguish between a depression screening tool and a screening tool that's used for SBIRT, right? So if you have 2 99420s on a record, you're not going to be able to tell at first glance which screening process is represented in that code. The other caveat is that the 96217 currently pays less than the 99420, so that may be a consideration for some practices in terms of deciding which codes to use. All right, and again, the CCO incentive metric includes not only screening, but also the follow-up plan. So there should be some basics for documentation of everyone who gets screened. So obviously what screening tool you used, what the score was, and how you interpreted that. Was that a pass, a fail, or borderline, or however you want to interpret that. And then we usually go through some specific guidance subjects that are discussed. And there are certain pieces of general mental health hygiene, if you will, that we think are important to talk about with all kids. So things like positive capital, sleep hygiene, good diet, getting regular exercise, and things like that. And then also specific follow-up plans for those patients who are identified as being at risk. And so from the CCO incentive metric guidance documents, the follow-up plan is the proposed outline of treatment to be conducted as a result of a positive depression screening. So there are certain pieces that must be included. You have to have at least one or more of the following within your follow-up plan to count in the metric. Any additional evaluation. So for example, my practice has embedded in a teen screening tool that we use, that one of those broad strength and risk-based screening tools. We have the PHQ-2 embedded in that, and we have the CRAFT embedded in that. So for us, when we have a positive PHQ-2, our next step is to do the PHQ-9. The PHQ-2 is a screener, the PHQ-9 is diagnostic, so that is our next step. And so the documentation for us includes the PHQ-9. Clinically, we think it's extraordinarily important to do a suicide risk assessment. I hope that goes without saying. And then if there's a referral that's done, any pharmacological intervention, some providers do first-line medication management of depression, so that would be part of our follow-up plan. And then any other interventions or follow-up for the diagnosis or treatment. So if you do any specific follow-ups with that patient, then that would be documented as well. Now, this is a screenshot of how my practice has specifically done this within our electronic health record. So this is just one of the forms that we use. And the part to pay attention to, we have the adolescent questionnaire reviewed. The cardiac risk answers, that's the part of the screening tool that we give the parents. So for us, you know, we've seen a lot of patients who have been going to these free heart screening clinics, and we had tons of false positives. And so what we do is we give the family a list of questions that are meant to screen which kids are going to be at risk for sudden cardiac death if they play sports. So while the teenager is filling out their form confidentially around depression and substance abuse, et cetera, the family has a fairly long questionnaire that the parents have to fill out as well. And so the parents are kind of busy doing their part, not really paying attention. But the important part is we have a place to document the results of the PHQ-2 and then a place to document the results of the CRAFT. And if a patient has a score of 3 or higher, which is a positive on the PHQ-2, we've included the decision support so that the PHQ-9 is automatically will pop up there to remind the provider you have another step to do. And so if you click on the print PHQ-9 blank, what that does is sends the form to the printer so that the provider can give it to the team and have them fill it out. The add PHQ-9 form actually is where we document within our electronic health record. So then we have another form where we go through the PHQ-9 questions, and that we use that modified adolescent form. And then from there, if that's positive, we have another form that pops up that has our follow-up plan so that we can document the components of the follow-up plan that are recommended. For the craft, similarly, if we have a score of 2 or higher, then we have a secondary form that will pop up automatically that allows for providers to document the results of that. And so that's kind of how we've attacked this from a clinical perspective. I think it's important when you're dealing with providers in electronic health records to try to provide some sort of decision support for them so that we're reminded how to do the right thing. And then for us, if we have positives on these and we have to do a follow-up plan, then our providers would mark that particular document within the electronic health record as confidential so it's not accidentally released in portals or in medical records reviews. So that's sort of our workflow. And with that, I think we have time for questions. So let's open that up, I think.
Yeah, so if you have questions, you can type them into the question pane. And then one thing I just want to note is the resources. So again, we had intended for this to be a breadth webinar where we're kind of touching on the issues, and our goal was to make sure as people are diving into addressing these CCO incentive metrics, they're aware of the bigger issues that are important to consider. So in terms of resources, this last slide kind of has all the links to all the pages individually in the slides where we link to things. That has all of the links, and then it also includes a link to that Oregon Pediatric Society START modules that has specific trainings that would also be helpful. And then again, we've given you our 3 emails that you're more than welcome to contact us with questions, and then the email that the Oregon Health Authority prefers you to send questions. And again, we really encourage you to ask those specific questions because they have handled a lot of questions, and you know, there are important regional variations that are important to consider, and also your questions help them improve their guidance. So the more you ask their questions, the more they know how to improve the guidance for other people, because your question is probably one that somebody else has. So Kate, do you want to do questions only through the question panel, or are you going to open up the phone line, or only do it through the panel?
So for between now and 9, we'll maybe just do general questions through the GoToWebinar control panel. But if you're able to stay on after 9 and you really want to hop on and ask a detailed question, we can do that. But let's try and get through for time as many of them as we can before that, and then folks who want to stay on and maybe ask more detailed questions can do that then. Okay. So there's a message that I'm going to just read it because it is one of those more detailed questions. Okay. Someone said they received an AAP coding newsletter in October of 2014 that states that screenings and assessment for alcohol and drugs are included in the well visit. Any intervention 15 minutes or more can be billed with the 99408, 99409 CPT codes. We stopped using the 99420 because of these guidelines, but still include the V7 9.1 and V8 2.9. What are your thoughts on this?
So we've been doing the billing of the 99420 in addition to our well visit for probably 6 or 9 months, and have not had any regional pushback on that in particular. So I think that if you're looking at CCO incentive metrics and you're not putting any codes in specific to that, and it's only the well visit, I would have to go back and look to see whether you're going to get counted on that. So I have not had any problems using the 99420. I didn't see that specific AAP document. And what I guess I'm wondering is if they're talking about a conversation about alcohol and substance abuse in a well visit, or if they're talking about structured screening tools within a well visit, which is a different deal. I've not, again, run into any problems with using the 99420, and I've not known any practices outside of mine that have had problems with that either. So that's interesting, and I guess what I would do is check with your CCO and see whether that is working for your CCO, and then check with your health plans to see if that's working and whether or not you can use the 99420 within your practice. Again, I haven't had the problem, but it would be interesting to go back and talk to your CCO about that and see if they're able to capture what you're doing.
But again, one of the things that RJ mentioned is that when he does use that, he also uses a modifier 3.3. So the modifier 2.5 says that these were specific things that happened in a visit. The modifier 3.3 says these are also things that are recommended in Bright Futures. And because of the Affordable Care Act provision that Bright Futures recommendations need to be provided and that there can't be cost sharing on Bright Futures recommendations, that is what has been a helpful tool in terms of sheltering some of the additional costs. But I'd be more than happy to follow up with metrics and scoring about the 99408 and clarification within the guidance.
Yeah, I think that most of us in pediatrics we don't spend, particularly on the negative screening tools, we don't spend 15 minutes on those patients. So, spending 30 minutes is almost out of the question based on how our workflow usually goes. And so even spending 15 to 30 minutes is unusual for some of these patients. And I think that, for me, the positives, I'm usually doing my motivational interviewing in a less than 15-minute time frame. So it wouldn't be capturing that without the 99420, at least that they've been screened.
Excellent, and we have a few more questions. Again, folks, we can hang out just a few minutes or several minutes after 9 to get questions answered because there are several. So are there any standardized suicide risk assessments that you would recommend?
Yeah, and that's a long conversation as well. And in fact, we did a webinar about that for some of our practices. And I think that in general, the PHQ-9 modified for adolescents is going to have those follow-up questions. And so that's what we generally use as our first screening tool. The question after that is, what do you do in terms of a safety plan versus, not doing a safety plan? And the evidence is really a little sketchy that safety plans do anything besides make the provider feel better about themselves, unless you're kind of going through a strength-based, step-by-step, here are some things that the patient can actually do if they start getting into crisis. And so there, we can go through a lot of detail, and I can send you some of those slides individually if you're interested in hearing about how you do the follow-up plan for somebody who is identified as having suicide ideation. But in general, the initial screening questions are going to be in that PHQ-9 modified for adolescents. There are two questions. One is, kind of current, and then the other is ever have you had those kind of thoughts. So so that would be the first step to me, would be to do that PHQ-9 modified for adolescents to get those questions in. And I think that again, just never underestimating the power of some sensitively asked questions in the visit as well. So you don't have to use screening tools for all of this. This is part of our clinical assessment, that we can be having a conversation with our patients as well.
I do see that, I'm just looking in the updated SBIRT documentation to get back to, sorry, the 99408, because that was bothering me. I do see in the updated documentation from December 2014, the revision, that they do include the 99408 used for patients who were screened and received a brief intervention 15 to 30 minutes.
Right, but the question, the question was about not using the 99420 anymore because it was supposed to be included in the well visit.
Yeah, yeah.
So that piece, I haven't had anybody run into problems with that, but again, we can kind of follow up and see what else, specifically. And I'll ask my billing office to see if we've had any bounce backs, which is probably the best indicator of whether it's working.
Right.
Okay, so we had another question about how long do you allow for adolescent well-child visits? The screen and intervention seems to be able to take up to 30 minutes extra.
Yeah, and I think, I'm still on a 20-minute schedule for my well visits, which is either perfectly fine or extraordinarily painful, depending on how things go. But in my clinical view, I guess, if I run into a patient who has a positive PHQ and a positive SBIRT, or one or the other, then a lot of times I'm going to abandon the other topics that we talk about, address the immediate safety issues of that family and patient, and then schedule a follow-up to spend more time with them, right? So I don't necessarily assume that I need to go through my other pieces of my normal well visit at that time if there's an immediate safety need or an immediate concern. But I think the important piece is sort of triaging the immediate needs and then scheduling a very careful follow-up so that you have more time to spend with that family or with that patient. So yeah, I mean, those are the visits where I'm going to abandon ship talking about necessarily eating your vegetables and, cutting down screen time or things like that. I'm going to really address the immediate needs and then schedule a follow-up to go through more detail. And then, if my day goes south and I'm spending more time with that family, that's just the way it is that day. So, so yeah, it's certainly what we all fear, I think, but again, to me, it's really about sort of triaging the immediate safety needs and then figuring out a careful follow-up.
And I think that's partially why it's kind of looking about the broader context of all the time that the adolescent is at the visit, and how do you kind of build in different parts to kind of what can you do in the waiting room, how can you do that in a way that still addresses them feeling like their results are going to be shared with their provider in a way that feels comfortable to them. The other thing,
It'll come back.
It'll come back. What's another question?
There's so again,
percent kids. Sorry, just in terms of the amount of kids that were screened, there's a project with the Oregon Pediatric Society, again funded by OHA, and then looking at the rates of adolescents identified, one of the first things people say is, oh my God, it's going to be 70% of adolescents. And then looking at the rates, they don't look that high. It's obviously varied by practice and region, but they have been, around 10% or depending upon the tool, 15%. So it hasn't been every single adolescent that all of a sudden that visit is blown up. And it's something we're going to keep tracking and be interested in looking at.
Excellent. And then so we are right at 9 a.m., so I know some folks have to get off to whatever's next in their day, but those of you that can stay on, we do have another question. If you have any other questions, please do feel free to submit them now. If we can get to them, we will. And like Colleen mentioned earlier, we do follow up via email with anybody that we can't get to. So if you still have a question, you can still send it in. One that we do have is, what diagnosis codes do you use to support depression screening, and how do you manage a negative screening?
The honest truth in my practice is that we have not billed for the depression screening part. Since it isn't a claims-based measure for the CCOs, we've been documenting it, but we have not been billing for it. I think that, yeah, I'm trying to think of any practices that I know and that have done specific billing for it. The two codes, again, that you can use in terms of the 96127 and the 99420 would be your best options. And certainly the 96127 is a new one that's been promoted by the AAP, and it covers a number of different mental health and social emotional screening tools at all ages, actually. So I think that I would have to look at what V code you would attach to that, but I would assume that there would be an appropriate V code for that as well. But again, the bottom line is that while my practice has been billing for the SBIRT and for the craft screening, we have not been doing the depression screening billing as well.
And then managing a negative screening?
Yeah, so I mean, again, in terms of the negative screens, I try to have a conversation with patients about kind of keeping themselves in good health in general, and again, going through some of those positive capital things, making sure the kids have some of the resilience factors, I guess, that we look at, so that they're contributing, they're connected to other people, that they're doing activities that they enjoy, and so forth, so that even in the context of a negative depression screen, that we're still talking about, you know, sort of the health promotion aspects of mental health as well. And resilience is another enormous topic, but I kind of, when I go through my strength-based screening for families, I try to figure out what the patient's goals are, where they're trying to go, and if they have a good understanding of how to get to their particular goals, and what sort of things they would need to do to make that happen. And in that, I am sort of taking a mental inventory of their assets and the factors of resilience that are going to help protect them. And then, you know, identifying what things I think they might need to work on if there's something that's missing that might be a risk factor. So, you know, I think that there's always a positive health promotion message that goes even with a negative screen. It's brief usually, but I think it's always important to kind of do that piece of the promotion. And the other thing that I think is important, even in the context of a negative screen, is that in my view, screening tools in general, a good screening tool is going to be educational. So even if a family says, or a patient says, you know, I'm not depressed, I want to make sure that they know that that's still an open door, right? So the fact that I've talked about that particular subject gives them the idea that if they ever feel like things are not okay, this is a perfectly appropriate place to come if you're not feeling well, right? And so we include that in some of our written documents as well, just to say, okay, so, you know, contact me if, but I think that's part of the messaging even on a negative screen, that, you know, I'm glad that you're doing well. If you're ever not, come find me. And, you know, part of our confidentiality conversation has to do with exactly that, you know, if something is not going well, I want to hear about it, even if it's something they don't think is necessarily health related, that it may still be something that we need to talk through. And, you know, just as long as I mention the conditional confidentiality, the way that I usually phrase that with adolescents is that, you know, we talk about the privacy laws and how by the time they turn 18, they're going to be expected to take over their health care. And so I don't frame the confidentiality as, you know, we're going to kick your parents out so we can talk about sex, drugs, and rock and roll. I frame it as a growing responsibility sort of a conversation. And then I say to them that, you know, in general, you know, what we talk about, I don't share with anybody unless we feel like we need to get help for something, in which case we're going to talk about who we tell and how we do that, so that patients know that, you know, and sometimes that's because it's bumping into the limits of my knowledge, and sometimes it's because there's a safety issue. And so my patients know that there are certain things that I might have to get another physician involved with, there are certain things that I might have to get a family involved with, but that I would never do that without having a conversation with them first about how that's going to happen and who we're going to get involved. I use the analogy of an appendix. You know, if they have an appendicitis, I'm going to have to tell somebody about that because I don't know how to fix that. And so, you know, those are the kind of examples that I think make sense to the teenagers.
Excellent. So I want to thank, it looks like we've gone through all the questions. Again, the presenters provided email addresses if you feel like you still have some lingering questions. So we're going to go ahead and end the webinar. Thank you very much to the presenters and for everyone for hanging out the extra few minutes past 9 to get to some of those last questions. About 1 million people asked about whether or not the slides will be available, and they will. They'll be posted along with the recording to the Institute website later today. And everyone who is registered gets a follow-up email reminding them of where that the slides are kept and located. So look for that email from GoTo. And thanks again to everyone for joining the webinar today. We hope it was helpful.
Thanks, Kate.